Hello, this lecture is going to look at hypertension, and I think it's the World Health Organization defined hypertension as a resting blood pressure above 140 millimeters of mercury over 90 millimeters of mercury in a patient aged less than 50 or above, and 160 over 95 millimeters of mercury in older patients. If we consider normal range for blood pressure, then it would normally be considered of a systolic of between 100 and 130 and a diastolic of between 60 and 80. Hypertension is considered to be a long-term medical condition in which the blood pressure in the arteries is persistently elevated, and is a major problem with regards to the development of cardiovascular disease and the development of atherosclerosis due to the damage to the endothelium, and also it's a major problem with a major cause of stroke, and that's why there's been a public health, it's a major class as a major public health issue, and most people over 40 are now regularly checked by their general practitioner to maintain their blood pressure within normal ranges. Just as a reminder, if we talk about the diastolic, which is the second reading, then this refers to the blood vessel, the pressure in the blood vessels when your heart is resting between beats, and the systolic blood pressure, which is the first one and the higher, is the maximum pressure your heart exerts whilst beating. Etiological classification, and there appears to be two types. We have the primary or essential hypertension, in which is between 90 and 95% of all cases are either primary or essential hypertension. And this seems to be a result of a complex interaction of genetic and environmental factors, and we will talk about some of those further on in the lecture. And then we have secondary hypertension, which is a elevated blood pressure to an identifiable cause. Again, about 5 to 10% of cases are a result of secondary hypertension. Conditions which result in secondary hypertension are Cushing syndrome and hyperthyroidism, and also we might see it in pregnancy with preeclampsia, and also as a result of renal artery stenosis. We can also have a pathological classification, and we talk about this benign hypertension, or the literature talks about benign hypertension, where we get this stable elevation of blood pressure over a number of years. And we do know that increasing blood pressure, blood pressure increases as you get older. And then we've got malignant hypertension, which is this sudden rapid elevation of blood pressure over a short period of time. This malignant hypertension can result in organ damage, blurred vision, chest pain, shortness of breath and headache, whereas benign hypertension can typically be silent and only picked up as an incidental finding. Causes of primary hypertension, then we've got this genetic predisposition. We know that if there's a family history of hypertension, then there is an increased likelihood that your patient will develop hypertension also. Socioeconomic factors, we know that alcohol raises blood pressure. We know that smoking and lack of exercise are also related to development of hypertension. From a dietary factor, high salt intake and vitamin D deficiency. They've noted that those patients who have vitamin D deficiency have increased blood pressure, and that high salt intake can cause alterations in osmotic movement of fluid and an increase in body fluid and blood pressure in the kidneys. Hormonal factors, insulin resistance or diabetes, insulin resistance, renin aldosterone is also which controls vasodilation and constriction, will also have an impact on blood pressure. And we know that probably the central nervous system and the sympathetic and parasympathetic divisions of the autonomic nervous system can also have an influence on the on blood pressure. Vessel changes in benign hypertension. Well, changes develop gradually. We know that there'll be a slow increase in blood pressure over time with benign hypertension. We will get some hypertrophy and thickening of the tunica media, and if you did your reading, your pre-reading for this topic, then you would have looked at the structure of the arteries and looked at the tunica media. What we see is hypertrophy and thickening of this. We also see thickening of the elastic lamina, fibroelastic thickening of the tunica intima, and then we start to see hyaline deposition in the arterial walls. What we also know from increasing hypertension is that we might get damage to the endothelium, and that would be an initiating factor in the development of atherosclerosis as well. We talked a little bit of causes of secondary hypertension. Well, renal disease, due to the activation of the renin-angiotensin-aldosterone system, the endocrine system, Cushing's syndrome, hyperthyroidism will result in increases in blood pressure. Drugs, then alcohol, MDMA or ecstasy, cocaine will all have effects on blood pressure, as does some antidepressants and the oral contraceptive pill. So again, your medical history gathering is important in trying to establish possible causes of hypertension. Also pregnancy, the condition called preeclampsia, whereby we get an increase in blood pressure and we see protein in the urine, is a serious condition which needs to be managed, because eclampsia can result in mortality of both baby and mum. Effects of vessel change in benign hypertension, then we're going to see a reduced size of the lumen, increased rigidity, increased fragility. So if we think about reduction in cross-sectional area of the lumen, we know if that cross-sectional area is reduced by 70%, then we might start to see some symptoms of angina. Increased rigidity and increased fragility is also a factor with regards to benign hypertension. Vessel changes in malignant hypertension. This is where we've suddenly seen a rapid increase in blood pressure. Then what we might see is some acute destructive changes in the small arteries associated with the rise in pressure, and this can result in necrosis of the vessel walls. Effect of vessel change in malignant hypertension, then what we might see is cessation of blood flow through small vessels and multiple foci of tissue necrosis. So this rapid increase can cause tissue necrosis and cessation of flow in small vessels, which can start to be quite symptomatic. Disease processes associated with hypertension. Well, atherosclerosis, we know that hypertension will cause damage to the endothelium and the development of atherosclerotic plaques. CVA, or cerebral vascular accident, again is associated with hypertension and can result even two types of CVA we know about: infarction, whereby there's an occlusion of one of the cerebral arteries, or a hemorrhagic accident whereby the increased pressure causes a bleed within the brain. Cardiac failure is also associated with hypertension, as is renal failure. And again, that renal failure and damage to the renin-aldosterone complex will result in further increase in hypertension. Interestingly, as we've said right at the very beginning, hypertension is often asymptomatic. and in primary hypertension, no obvious cause can be found, and that's really important. We might see lifestyle change, lifestyle, or in investigating the patient's lifestyle, we might see risk factors for that, and that in some ways those need to be managed along with pharmacological management. Again, this algorithm is taken from the NICE guidelines, CG127, and again it's about how we manage pharmacological management of hypertension. We need to look at lifestyle always, so we need to gain about this patient-centeredness. We need to talk to them about lifestyle, we need to talk to them about exercise, diet, alcohol intake, all things that can contribute to hypertension. If you've got a person aged under 55 with hypertension, then from a pharmacological point of view, then they would normally be put on an ACE inhibitor. And if a person aged over 55, or a black person of African or Caribbean family origin, then we would look at a calcium channel blocker. ACE inhibitors, angiotensin converting enzyme, stops angiotensin 1 being converted to angiotensin 2 and therefore reduces vasoconstriction. Calcium channel blockers again are looking at effects on smooth muscle. If you're unable to manage with the ACE inhibitor or calcium channel blocker, then you would add the other. So if you've got an ACE inhibitor, then you would add the calcium channel blocker. And it escalates up from there. So ACE inhibitor plus a calcium channel blocker, and then add a thiazide diuretic. If you're still resistant to hypertension at that stage, the recommendation by NICE is that they are actually referred to a specialist, or there's further monitoring and drug treatment, but that they are referred for specialist intervention as such. Again, if you go on to this algorithm on CG127, it's again interactive, and it allows you to click on each, and it gives you a good, clear, concise explanation for the strategies behind each stage of the management of hypertension. Resistant hypertension, in those cases of resistant hypertension, consideration should be given to prescribing a higher dose of thiazide diuretic. If this still fails, then, as I said before, the recommendation from NICE is that you refer to a specialist for further monitoring and management. That completes the short lecture on hypertension. It is a major public health issue. We've looked at some of the management strategies, some of the causes. If you've got patients with elevated blood pressure, then you should be referring on for management in order to try and maintain levels within the normal range, which would reduce then the risks of cardiovascular and cerebral vascular accident. Thank you.